I just got a little live stream notice. Oh, there's a YouTube link.
Okay. Yeah, so we are live on YouTube. Good afternoon, everybody. I'm Travis Howe, Executive Director of Mountain Lakes. We're in between meetings today, in between REMAC and REMSCO. And our REMAC chair, Dr. Bombard, wanted to bring a little bit of education or some thought-provoking conversation to you. We also have Zach Boucher here from the Mountain Lakes office on the Zoom. So Tiff, we're recording and we're live on YouTube, and Zach should be able to chime in with any comments that he sees from people along the way. So it's all yours.
Fantastic. Thank you everybody for linking up to this. I know it was probably not the easiest process today, and I'm grateful that we're able to rebroadcast, unfortunately not live, but maybe some more people can see this afterward. This is a prototype. I think we're going to try and do a little education between the REMAC and the REMSCO meetings on a regular basis from now on. So this will be the first installment. I think probably the next one that we will address is sign-offs. So what do we need to accomplish to protect ourselves and to protect our patients when they're declining transport? How to appropriately do that from both, like I said, the liability standpoint and the patient care standpoint. So that'll be installment number 2 after the next quarterly REMAC. But today what I wanted to talk to you guys, or really with you guys about as best we can, is what to do with families and with patients now that we're leaving more and more patients at home after a resuscitation attempt. We're not going to back off of the current guideline anytime in the foreseeable future, probably never, that guides us to finish our ACLS algorithm in place and then terminate resuscitation if we haven't gotten ROSC and transport only with return of spontaneous circulation. So no more CPR in the ambulance unless the patient arrests in the ambulance on the way to the hospital, or unless there are extenuating circumstances, right? And we've talked about this in the past, but instead extenuating circumstances would be either you're in a threatened position at the scene, or you feel that the emergency department has some technology or expertise that you think might save the patient that you don't have at the scene. And that happens occasionally, but not that often. Most of the time you have everything we have in the emergency department to try and resuscitate that patient. And we want you to do it. We want you to dig in and do all of that stuff. And we're finding, at least allegorically, that we're getting more resuscitations in this method, not less. So we are more successful than we've ever been at bringing patients back, which is great. It's great news for everyone. But what we're also doing a little more of than we've ever done in the past is discussing end of life with families. And this is something that we should talk about as a group, and that I'd like to offer you some advice about, because it's something that I do more than I'd like and I have quite a bit of experience at, and that I've had some training in that you guys haven't had. So I want to share with you the training that I've had and the experiences that I've had. So what happens, right? We come in, we do all of our medical magic. We get an airway, we do CPR, we do our resuscitation, we get our IV or our IO, and we do a good strong 20 minutes of care, if not longer. And we decide, okay, we need to stop the resuscitation. What do we say to the family, right? We don't have to call for medical control permission to terminate, but often it's handy to do so. You know, it gives us a little added buffer, and it gives us a consultant to discuss with in case we miss something, which is great. And I don't know any medical control physician that has any opposition to sitting down and consulting with you and making sure that you did everything you should, if you want that backup. But at some point, you have to have a talk with a family member and say, hey, we're not going to go to the hospital, right? And so there's some technique to that. The first step for me when I talk to friends and family members of patients about end of life is I sit them down, right? And this is something obvious and it's something instinctive to all of us, I think. I think we usually sit people down when we have a discussion, but it doesn't always come to mind. And if you think of it first, it settles both you and the friend or the family member. And then this is something I was trained to do in medical school that I had never considered before. The first thing that I say is, I need to give you some bad news. And that allows the person to have some expectations, right? The person I'm discussing this with doesn't know necessarily whether I'm going to tell them, hey, grandma's going to be fine, right? Or, hey, grandma's not going to be fine. But if I preclude the discussion by saying, I have some bad news for you, I'm so sorry, then it allows them to kind of brace themselves for what's coming next. And I usually try and take a breath right after that, right? I let them settle into the thought that this isn't going to be their favorite discussion of their life, right? Okay. The next thing that I often do is I ask them a little bit about what had happened with the patient. Sometimes I use them as a historian so that I get a grip on what their understanding of the situation is. So it both gives me some information about the patient and their medical history and whatnot, if I haven't already gotten that. And often if I'm operating as a pre-hospital provider, I've already gotten as much of that as I'm going to get, but sometimes not. Sometimes the family member shows up late, right? They weren't at the house. They weren't the caller. And so in that case, I try and data mine a little bit, which allows them to talk a little bit and allows them to relax with having a discussion with me because they've never met me, right? So now all of a sudden we have some sort of collegial talk. And it allows them to feel like they're helpful too, right? Whatever history they can give me is something that they're contributing to the situation in a good way. And then we kind of have to move into it, right? Whether we have that part or not, we have to say, okay, these are the things we've done. And when I describe the care that we've given their loved one, I try and use as few medical terms as possible. Now, this is, again, something that we as EMS providers are really good at, right? Boiling it down, taking all the medical jargon out of it. Often emergency department providers are less good at this, right? They'll talk about procedures and use words that the normal people just they've never heard these words before, and they don't need to be learning a new vocabulary today under these circumstances. But keep it in mind, right? This isn't time to show off. This is a time to connect, right? And try and educate people as to what you've done in the simplest words possible, so that because they're doing a lot of heavy lifting here, right? They don't need to lift any heavier than they already are. But I do try and say, hey, when we came, your grandmother didn't have, her heart wasn't working at all and she wasn't breathing at all. And so we had to put in a breathing tube and breathe for her. And we had to do CPR in place of her heart working to get her blood moving around. And we gave her lots of medicines to try and get her heart restarted. And we gave all of the medicines that the hospital has. We have them with us. We did all of the things that the hospital would do because they've trained us to do those things, because that's part of taking good care of people. And none of those things worked. So it's time to let your grandmother die naturally, right? It's time to let her die a natural death. And so we're going to stop, or we have stopped. Because anything more that we would do was not going to help her. And those are pretty easy words, right? They're pretty easy words to understand, but sometimes you really need to repeat them a couple of times, and don't be demeaning about it. But this is a lot to take in. And remember, that the person you're talking to is under an enormous amount of stress. This is usually the first time around for them trying to digest something like this. And their expectation was that you were going to load and go, right? And that's not what you did. So you have to sell this a little bit and make them understand that this was the kindest thing that you could do for their loved one. And that doing more would not be helpful to them. In fact, would just, for lack of a better word, torture them. I wouldn't use that word necessarily. But it's important for people to understand that you wouldn't be successful under any circumstances if you went anywhere, right? And so it's time to let their loved one go naturally. This is their time. Zach, are we picking up anybody making comments? Because I would love some questions or comments. Oh, Zach wandered off.
Stand by, let me check YouTube. I don't see any in here yet.
Okay. Please, if you're watching this live, I would love to have some contribution from you, because talking to myself is really not as much fun as it could be. And I'd really like to cater this to what people need. So you can think of some things that are helpful to say, right? So you really want to spin this in the kindest way and still be direct. You want to say your grandmother, grandfather, mother, father person has died, right? And you want to say the word died. You want to say that that this person is dead, and you want to say that D word a couple of times. You don't have to beat them over the head with it, but you do need to lead with it, because as we all know, when you use euphemisms like has passed on, it's gone to a better place, that sort of thing, it allows for denial that's not helpful. Other things that you want to avoid, right? Other than those gone to a better place sort of things. Try and avoid giving this person your experiences, right? You may have had lots of experience with your loved ones dying, and you may have been in exactly the same shoes as the person you're talking to, but remember, they don't want to hear it, right? They don't want to hear that you understand. They don't want to hear that you've been in their shoes. They need to just hear that you're sympathetic, right? Because in their spot, they're going to feel, no matter what you say, they're going to feel that they're the only person that's ever experienced this sort of grief, right? And it's their right to feel that way. That is okay. They are never going to believe that you have felt what they feel, even if that is the case. So don't even try to go down that road. Just plain listen, right? Let them tell you some stories if they want to. Let them tell you a little bit about their loved one. That's fantastic. That's great therapy. That's great patient care for the person that you're talking to. And that's now your patient, right? The dead person is now no longer your patient. You don't do dead. You do resuscitation attempts, but you don't do that. That's not your job. But you certainly do, patient care for families. Your focus just changed. So your job now is to give them as much peace with this situation as they can possibly have. And that entails listening and not a lot of talking, and trying to solicit them, telling you a bit of a story here or there. And sometimes, you can connect with people to the point where this becomes the best call of your day, not the worst call of your day, because you know that you gave some peace to a family. And it's all about spin. It's a little bit about technique, manipulating people, all of that stuff. If you want to, make this less touchy-feely. But it all really boils down to being empathetic and being kind. And you guys are great at those things. And making connections, which you guys can all do. Every last one of you can make connections with someone in 30 seconds or less. It's what you do every single call when you want to. And it's just a case of wanting to. So let's boil this guidance down. 1, sit down, sit them down. 2, give them a warning shot, right? I'm going to give you some bad news. 3, use the word dead, but use it gently. 4, tell them a lot about what you did in very simple terms. 5, solicit their input. And 5A, forgot about this, praise them, right? If they called you, if they started CPR, tell them they did the right thing. Tell them that they did everything possible that could have been done, because there's a lot of guilt involved in this. If you're a family member and maybe grandma didn't feel great this morning, but you didn't call EMS until this afternoon, and you feel terrible about that, try and alleviate some of that guilt as truthfully as you can, right? Don't make stuff up. But if you can make somebody feel better about their situation with their loved one, that's a good gig. And then 6, just listen, right? Try and get them to tell you a little bit of information, and listen to it. Get them to tell you about a little bit about their loved one if they feel like doing so, and listen to them, right? And tell them you're sorry. You don't have to tell them that you're sorry. You know, you didn't fail, right? You did everything that you should be doing. Don't feel sorry about any of that, but feel sorry that they're grieving. That's an easy thing to make clear. And that's a really therapeutic thing for you to make clear to them. Don't be afraid to hug people if they start the hug, right? Don't go after them. That's creepy. But if they want to hug you, let them hug you if you're comfortable with that. That can make both of your days better. I think that's all I have for you.
So Patty notes that their death is very personal to them, and that she explains what will happen next so that they aren't surprised. And then, like, do they need somebody called, for example, clergy?
Fantastic. Thank you, Patty. Those are great words of advice. So, you know, everybody's system is a little bit different, whether you're going to wait with them for the coroner, or the police officer often does this for you. In some places it's a social worker, or a friend or clergy or whatever your setup is in your region, let them know what that is. And yeah, absolutely. Making a couple of phone calls for people is fantastic. Sometimes they would like you to call their sister or, you know, child and break some news for them. And that's okay to do if you're comfortable with that. And I would say, try and stretch yourself to be comfortable with that. That's a, you know, fantastic outreach service you can do to make somebody else's day a little bit easier. Because they're having the toughest day they've had in a long time. So thank you, Patty. Perfect. Anybody else have anything? All right. Any feedback? Please reach out to me. I think everybody has my email and my phone number. If you don't, then it's easy to find. And if you have suggestions for future topics, please let me know about those. All right. Thank you, everybody, for doing what you do. And thanks for listening. This is me staring at the camera until Zach turns it off. Turn off the camera, Zach.
Yeah.
Turn off the camera.
We're working on that.
Thanks, Zach.